Yeah, so for us, in radiation oncology, this is a rather interesting topic because, as a group, we really enjoy reading through the literature and debating the fine points of new studies, but there tends to not be that many items which actually change how we do things. And, especially the case for high-grade gliomas, because usually the solution for radiotherapists for diseases that are refractory to treatment is to either increase the dose or increase the size of the field. And for GBMs, we've done both. So, some of you might remember this, that it used to be that we treated GBMs with whole brain radiation up to 60 gray. Which is inconceivable now, but we did cover as much as we possibly could, and there have been studies boosting the gross tumor to 90 gray and to 120 gray. So there's not any more ways to increase the dose, and we've tried different fractionation schedules, once a day, twice a day, hyperfractionation, hypofractionation, and still no result. So then you say, well, after all that, what else can we do? Well, I think we can do less. So as time has gone on, we've tried to do less and less radiation because the cost of radiation is that you have side effects and morbidity from your treatment. And as time has gone on, we've tried to do smaller fields. And this is one example from the MD Anderson group, where they took much smaller margins on the boost volume, so 0.8 centimeters instead of the usual 2 centimeters on the RTOG protocol for the gross tumor. And what they show is what we've always shown, that it matters not too much what you do. The recurrence rate's about the same, and the site of the location of the recurrence is about the same, right? It's always in the high dose area. And so there's always been a lot of controversy about how much margin we really should do for GBMs. And it's almost become religious that, whichever group you have faith in is the margins that you do. However you got trained is what you do. So for, I think the most standard protocols are either the ROTC or the RTOG protocols, right? So 2 centimeters on the gross disease, or in RTOG, 2 centimeters on the flare with a boost that's 2 centimeters on the gross disease. The advancement over the last couple years is that there has now come out a consensus statement that those are not the only 2 allowable margins. So now there are 4 acceptable margins, and the smallest one is from ABTC, which is also a 2-phase treatment plan where it's 5 millimeters of margin. And so for somebody like me who trained under RTOG rules, having 5 millimeter margin scares the bejesus out of me, right? But they have prospective studies showing that people fail at the same rate and people fail at the same location. So this is the first practice-changing innovation for us, which is there's been a much more general acceptance of very tight margins now in GBM. And so for us, for our group, we've tried to maintain the RTOG margins while we can, but we have tended to allow down to 5 millimeter margins if we need to for critical structures. And so, we don't feel as bad anymore with smaller margins all the way down to 5 millimeters. The second thing that we can do with radiotherapy is make the treatment courses shorter. So the standard treatment course is about 6 weeks, and for patients with poor performance status who are frail, 6 weeks is a long time. And so there's been quite a few studies looking at shorter and shorter radiation courses. So this is a study that's that was presented at recently, I think, ASCO, where for elderly patients, they randomized 40 gray and 15 fractions, so 3 weeks instead of 6, and they randomized to radiation alone versus radiation plus concurrent temozolomide. And in this study, they found improvement in overall survival with the addition of temozolomide. Which is kind of nice, right? Because it says that for this group of patients who are poor performing, even then you can enhance their outcomes with a 3-week course of radiation and temozolomide. So for us, for patients who are a little bit more frail but who can tolerate chemotherapy, we've begun to adopt this protocol rather than the standard protocol. And then there's always shorter, right? So you can go shorter still. So this is a recently published study, phase 3, again, frail and elderly patients, where instead of a 3-week treatment, this study treated patients over the course of just a single week, so even faster. And the randomized arm is 25 and 5 fractions versus 40 and 15 fractions. And you'll remember that 40 and 15 fractions was the losing arm of the previous study. So with these two studies combined, then we have 3 gradations, right? So patients who are doing great get standard treatment. Folks who can't stand standard treatment but can do chemo-RT get chemo-RT with a 3-week treatment. And for folks who are not able to tolerate that, they can get by with 5 days worth of treatment. So that's changed how we do things. So the critical part of having tight margins that we talked about before is that you need really good imaging protocols to make sure you don't miss, right? Because the slop factor has decreased dramatically. And I talked a little bit about this before, that there are now consensus guidelines for imaging protocols in this group. So less for us, but for a lot of folks, this may change how they go about their imaging. So this, I think we also talked about in a previous study, which is that we've always known that whole brain radiation gives better local control within the brain, but at the cost of toxicity. And so this was our TOG study with hippocampal sparing whole brain radiation that showed decreased toxicity relative to traditional whole brain. Which is pretty nice. But if you look at that study, the really interesting thing for us was that if you compare these patients actually by the same criteria as our chain study out of MD Anderson, where they compare SRS versus whole brain and SRS, this group of hippocampal whole brain radiation actually had the same amount of cognitive decline as the radiosurgery patients from that study. So what it promises is that you can get improved local control of whole brain at the cost of cognitive decline that's the same as SRS. So, it's something for nothing, right? So that's pretty nice. And for whole brain patients, of course, there's a randomized trials that they can be on, they can participate. But I think for our group, this study changed for us more than just a whole brain radiation. Because if you think about it, patients who have brain mets have already a fairly limited time of overall survival, right, despite best treatments. And so while it's worthwhile trying to spare their cognitive function, maybe they're not the impact may not be the biggest in this group. But knowing that sparing the hippocampus spares cognitive function, we started to incorporate these dosimetric criteria onto our other patients. So patients who are likely to live a much longer amount of time. Because before this, even with IMRT planning, we would spill dose into the hippocampus willy-nilly, right? Because there would not be a dose confining structure there. So the way that this study has changed our practice is that for benign indications like meningioma or even for low-grade gliomas, where we can, we try to keep the hippocampal dose less than the parameters set forth by this study. And then the last part is this, and I think we touched on this briefly, which is the treatment, the Optune treatment, right, of rapidly alternating electric fields. So the paper that came out recently was one where this treatment had an overall survival benefit, not just for the recurrent set of patients, but also in the upfront definitive set of patients. And if you look at these curves are about as good as you're going to get in GBM, right? So we haven't seen this kind of shift in the curves for quite a long time, not since temozolomide. And the issue that folks have had with it, of course, is that the mechanism of action is a little bit mysterious to most of us who haven't worked in this field, one, and so there's some skepticism. And two, this was a randomized study, but it was not a randomized sham-controlled study. And especially for device studies, having a sham control often makes a significant difference. And so, so I think this is something that is likely to change how we do things in coming up, although we do it with a little bit of trepidation. And so, so for us, the standard of care, especially for GBM, is still continues to be maximum resection followed by RT with concurrent and adjuvant temozolomide. For frail patients, we're moving to 40 gray and 15 fractions with temozolomide, and for very frail patients, we're starting to move into 25 gray and 5 fractions. So trying to pick patients properly so that they get the most benefit from their treatment with the least amount of toxicity and the least impact on their quality of life in the remaining time that they have. As part and parcel of this, we're taking on consensus imaging guidelines so that we can make sure that we don't miss even as we try to decrease toxicity. And we're, as part of this decrease in toxicity, we're working hard to integrate new structures to save, for example, in our hippocampal sparing techniques.